Hello, everyone, and welcome to the second question and answer session hosted by UAB's Neuroinflammation, Pain, and Fatigue Lab. This is a live broadcast, and it's through YouTube, as you can see. The lab is also called the Younger Lab. We're coming to you from Birmingham, Alabama. My name is Tina Tidmore. I am an ME/CFS and fibromyalgia patient, and I'll be facilitating the discussion today. I have two helpers, Joe Lanson and Cindy Lee. The first broadcast we had that was a question and answer session was on March 3rd, and we had so many questions we couldn't get them all answered. So Dr. Younger's decided to do these monthly until we get all the questions answered. Today's topic is, what is fibromyalgia and what is ME/CFS, or sometimes known as chronic fatigue syndrome or by other names? And it's part 2. So we're going to try to keep the questions focused on the topic of the disease, theories about the disease, and what may be the mechanism for the disease. In future broadcasts, we're going to be looking at questions that have to do with treatments and more details about the research that's being done at the Younger Lab. Let's see. The next thing I need to talk about is some things that we found out in the March 3rd broadcast that bears repeating for those of you that are not familiar with the Younger Lab. It is at UAB, and that the full name is the University of Alabama at Birmingham. There is another university in the state that is called the University of Alabama, and that is different. So when you refer to where the Younger Lab is, we ask that you use the whole name, University of Alabama at Birmingham, or you can just use UAB, which is what we do here locally. The Younger Lab opened in July of 2014. That is when Dr. Younger came here from Stanford University. And he said in the March broadcast that he has about 20 working with him. He said he's had positive response from the administrators and doctors and other researchers. And he's been in high demand in giving presentations about his work and some of the discoveries that he's had. The Younger Lab is for research only. They do not provide clinical care, but they do hope to have that in the future as the lab continues to grow. Dr. Younger also said that he's developing clinical trials or a clinical trial section of the lab, and that's going to require some private funding. Dr. Younger's theory is that many chronic illnesses that have chronic pain and chronic fatigue are from neuroinflammation, where the brain's immune system, that is the microglia, has become sensitized so that it becomes active when it's not supposed to be. And this causes a sickness response of cytokines being released that make a person feel sick, like they have the flu. So let's bring on the researcher for today. Hello, Dr. Younger. We can see you now.
Hey, can you also hear me?
Yes, I can hear you.
Perfect.
Did I summarize your theory pretty much accurately?
That is a very concise overview of what we do, what we believe. Yeah.
Okay, great. Then the other thing is, do you have any news that you'd like to share with everybody, that any new developments at your lab that's come up since the March broadcast?
There's stuff every week. There's things to talk about that's new. I guess the most exciting thing right now is, as I mentioned in my last YouTube video, not the question and answer, but the one on hot brains, the brain thermometry, is we got a grant, $75,000 from a rheumatology group, Rheumatology Research Foundation, to study this brain thermometry technique, which is our scanning technique to look at brain temperature. People may have questions about that scan, but this is our first money specifically to do that in various groups. And we're also submitting a new grant application to the NIH because NIH just released a new grant mechanism specifically for ME/CFS. And so we're submitting an application to do brain thermometry scans in ME/CFS, and I think there's a good chance that's going to get funded. I can't say for sure, but so I guess the short story there is we're going to be putting a lot of attention into this new brain temperature scan, because if it works like we think it will, we'll have a pretty good diagnostic tool and also a biomarker for when someone responds to a treatment. I think that'll really help fibromyalgia, chronic fatigue, and a lot of other conditions. So we can talk more about that scan if people want to, but it's good that we're finally getting some money behind that project. So I think it's an important one.
And are you calling for subjects for any particular study at this time?
Not officially yet. I would tell people to keep an eye out probably in a month. We have to execute a little bit more paperwork on the one for rheumatoid arthritis. So we will be looking for people with rheumatoid arthritis who are receiving the standard drugs, but they still feel really fatigued and maybe have some cognitive issues. We think that that happens when your body responds to the drugs, but they don't get to the brain, so you still have brain inflammation. So again, people with RA who are still really fatigued, even if their joints feel better, and we'll be recruiting that pretty soon. I'll put out something on Facebook, and we'll also release a newsletter and let people know as soon as we start recruiting. Then probably also in about a month, we'll start recruiting people with fibromyalgia or chronic fatigue syndrome. So just keep an eye out. If you've already done the online screener, we'll be looking through that to find good participants, and we'll contact them and ask them if they're interested. So the best way, really, if people do the online screener, and I can set out a link for that, that's the first thing we go to when we look for participants. So that's what I recommend people do.
That's on your website, right?
There is
the link to the screener.
Yep, there's a link on the website.
Okay.
I can also post the link directly to the screener and in the comment section of this. So we'll put that out.
Okay, great. Well, I guess we're ready to go on to some questions
Sure.
here. All righty. Number one, what one thing would you advise a patient tell a skeptical medical provider about ME, CFS, and fibromyalgia?
It's really tough. I think the first piece of advice here is something you probably already know, which is the physician-patient relationship is based on trust. If you have a lot of symptoms and your physician or clinician does not believe you, then you don't have a good relationship with your treating physician. That's a bad sign. Your physician has to believe you. And I know not everyone has options to move around, and again, you probably know this, but the first step is if you're in a position of having to convince your doctor that something's wrong with you, you don't have the right doctor. So if you can find someone who's more who believes you, that's the way to go. I can't tell you if you have a skeptical clinician, I don't know what you could tell them. I don't think you can bring them papers from our lab or any other lab and they'll look at them and go, oh, okay, I believe you now. I think if you have a skeptical clinician, they will be skeptical for a long time. I'm not sure you can change it. We are working, and other groups are working on the studies that might accomplish that. If we have something that is truly concrete, you can't debate it, it's in a large sample size, and it's repeated, then you may have something you can take to your physician. But honestly, in the meantime, I can't think of what you would say that would really change most of their minds.
Okay. Similarly, someone asked, how would you describe to my relatives why I can't function like a healthy person? So we know you don't provide clinical care, but many doctors end up having to explain to relatives why the person may look okay and have times of function, but then cannot function like a normal person. So what, if you were to sit down with relatives of a patient, what would you tell the relatives?
So assuming this is fibromyalgia or chronic fatigue syndrome, I would have that family member try to remember the absolute worst case of the flu they ever had in their lives and say that's basically what it is. When you have the flu, you can't get out of bed. You can't go to work. You can't think. You just want to sleep all the time. And it's so hard to function and so hard to focus. So have them think about that and remember, and then ask them, how much could you really do if you had the flu every day of your life? Because inside the central nervous system, that's exactly what's happening. You don't have the runny nose. You don't have the cough. those are the peripheral symptoms. That's a different pathway. The central symptoms, the fatigue, the cognitive problems, the sleep problems, that's what's being activated in fibromyalgia, chronic fatigue, and it is just as severe as if you had a severe flu. So I think it's important for people who don't follow the science much to realize that those symptoms of the flu, the things that make you feel horrible, that's a product of your immune system. And your immune system can produce that in you even if you don't have a viral infection. That's when it's dysregulated, but the body doesn't know the difference. So I guess that would be my first response to that, and hopefully that helps.
We have many patients that when they first go in and they talk to the doctor, they will say, it feels like I have a flu, I can't get
Sure.
over it, and stuff
Yeah.
like that. So that is the way patients sometimes describe it as far as how they feel.
That, and then the second most common one is I feel like I've been hit by a truck. And incidentally, that's exactly how people with a horrible flu describe it. I mean, the language is identical between the two. And that, I think that's meaningful. It doesn't necessarily mean they're the same thing, but you have to pay attention with the symptoms are the same. And if the way they describe it are the same, that suggests that a similar pathway is involved in both of those. And that's what we think is happening. Yeah.
Okay. How often do you see that the people with fibromyalgia or ME/CFS also have ADHD? Have you seen that in your own studies, or have you seen other studies that show a comorbidity or association between ADHD and fibromyalgia and ME/CFS?
So ADD is a attention deficit hyperactivity disorder, and that I don't know if the terminology has been changed in the new DSM-5, the kind of psychology psychiatry manual. I haven't kept up with that, but I haven't seen or haven't heard any relationship between ME/CFS and ADHD, and the emphasis is on that H part, the hyperactive part. When you have ADHD, usually these are individuals who can't control kind of their behaviors, so they're hyperactive and they're running around. They can't sit still. That kind of conflicts with a lot of times how we see ME/CFS. What I would say though is that the cognitive impacts of ME/CFS can mimic ADD, which is just attention deficit disorder, because you have a lower focus, you have lower concentration, you have lower memory. So I think it could mimic ADD. The difference is the treatment would be different, because ADD you can treat with psychostimulants that increase dopamine in the prefrontal cortex. I'm not sure that's going to help with ME/CFS, and I think it's been tried before and it's not very effective. So the bottom line is I think ME/CFS cognitive stuff and ADD cognitive stuff are different problems.
So someone else asked, how prevalent is allodynia in your fibromyalgia? Now, I thought fibromyalgia was allodynia, which is pain sensitivity or, over responsiveness to pain. So then the question may be, are you measuring that particular aspect in the fibromyalgia patients that you are studying?
Yeah. So there's two terms to keep straight. One is hyperalgesia, which is where pain is exaggerated. So fibromyalgia people will feel pain more than other people would feel pain. The other one is allodynia, which means that you feel pain when you shouldn't. So a good example of allodynia is if someone has complex regional pain syndrome, which is where they sprain their wrist and their arm swells up and turns red. With CRPS, if you were to take a feather and brush it on their arm, it would feel like fire to them, like their arm is on fire. That is extreme allodynia, because a feather is not supposed to hurt you. So fibromyalgia people generally have some degree of both hyperalgesia and allodynia. And I would say I'd say almost all people with fibromyalgia have some level of allodynia. And the way we test that is we use pressure. So we have a pressure gauge. It's called an algometer or a dolorimeter, and we press it on soft tissue points. And you slowly increase the pressure, and you write down when they first feel pain. If you have fibromyalgia, it's going to take a lot less pressure to elicit that first sensation of pain. So we would classify that as allodynia, and I would say virtually all the participants would show some degree of that. It's just a matter of degree, whether it's severe or not.
I see. I see. So do you, as part of criteria for participating in the research, do you ask in order to see if somebody has allodynia, or do you actually do that test? Or do you just find out if they're diagnosed with fibromyalgia and that's enough?
Yeah, allodynia used to be the core part of diagnosing fibromyalgia. That's from 1990, 1991. In the criteria of the American College of Rheumatology, that's where you've heard about those 18 tender points. That was the way you got diagnosed. That has been removed from the diagnostic criteria as of 2010 because everyone was doing it differently. They couldn't get the physicians and clinicians to do it the same way, and so it was almost useless as a tool. And so now the fibromyalgia criteria are self-reported. You ask them, do you have pain in your arm? Do you have pain in your shoulder? Pain in your chest? So to enroll in our study, you just have to meet the new criteria. However, we generally still do the pressure because we want that additional information. We still use it in our studies, but we don't use it to decide whether or not you can be in the study.
Oh, I see. Okay. Someone said, I was told fibromyalgia is not progressive. If that's the case, why are my symptoms getting worse?
Okay, there's a couple things that could mean. Not sure what who said that and what exactly they were referring to. There's two ways we can interpret progressive. One is just does it get worse over time, which is probably what they meant. From my read of the literature, fibromyalgia is generally progressive. You can expect over time that your symptoms are either gradually or sharply going to get worse. The last I saw, probably 25% of people diagnosed with fibromyalgia, if you look at them 10 years later, about 25% of them will be better. That means the majority of people diagnosed with fibromyalgia are going to be the same or get worse over a period of time. And I think probably about half at least are going to get worse. Now, a lot of people, that's a pretty slow progression, or it's a slow progression and then they get a viral attack and then there's a sharp increase and then it continues up slow and then they have a car wreck and there's another sharp increase. So it can be a slow progression that's punctuated by specific events that make it worse. Another way you can look at progression, it's not a progressive neurodegenerative illness. And sometimes when people talk about progression, they kind of mean that there's damage occurring. So I want to differentiate it from rheumatoid arthritis, which is a progressive autoimmune disorder. When we say progression in that case, it means it's actually destroying the joints. Or if you have multiple sclerosis, you're getting destruction of the central nervous system. There's no evidence that that's happening in fibromyalgia. So even though your symptoms may be getting worse over time, there's no evidence that there's increased damage to any system over time. So that may be a small comfort, but as I might have talked about before, at least it means if we can solve your symptoms, as far as we can tell right now, there hasn't been any lasting damage done to any of your organs. So that's better than other diseases where it actively destroys a lot of cells in your body.
So based on your theory of the sensitization, you're saying that over time, the neuroinflammation or the microglia can become either less sensitive or more sensitive, and that would make a difference in whether the symptoms get worse or get better. And that can be triggered by other environmental assaults, but the neuroinflammation isn't necessarily causing damage. There's no damage that's going to have symptoms linger. It's just whether the microglia are where on the spectrum of sensitivity it is.
Yeah, well, some people get better because they respond to one of the FDA-approved treatments or to other treatments. So this isn't people who, these are people who are receiving all the treatment. So sometimes just the treatment works, and maybe their problem wasn't microglia. Maybe they had something that looked like fibromyalgia, but it was caused by something else, and it responded. So there's multiple ways people can get better, or maybe they accidentally move away from the thing that was causing their symptoms to begin with. If it was a mold, and I don't do research into mold, but for example, if they had an insensitivity to mold particles they were breathing in and that caused their microglia to activate and they moved houses, they may start to feel better. So there's things like that. Low-level inflammation in the brain, as far as we know, should not be causing damage. Now, if you take severe neuroinflammation, that will damage the brain. but
Okay.
we haven't seen any evidence that straight fibromyalgia or straight chronic fatigue syndrome involve the type of neuroinflammation that will actually cause damage, as opposed
Oh,
to Alzheimer's, multiple sclerosis, other conditions like that. There is evidence that the brain will change, and you can say that certain regions shrink, but there's no evidence that the neurons are being destroyed. It just, the brain adapts to new situations. If you have pain hitting your brain all the time, the brain's going to change in adaptation to that. That doesn't mean it's neurodegenerative.
okay. So, another question. If exercise is supposed to help with pain, why do I get a big flare within a few hours
Yeah.
of exercise?
Um, so, without wading into the ME-CFS and graded exercise treatment stuff, it is extremely controversial for that reason. Exercise is a stressor to your system. I mean, in the medical community, you talk about exercise as being this panacea, it fixes everything, but it's still a stressor. If you push your body is going to interpret that as something, serious happened. Unless it's super low level exercise, you're going to have cortisol release, you're going to have an immune response, and some of those things can trigger the microglia. So I think, microglia threshold in fibromyalgia and chronic fatigue syndrome is very low. It takes very little to set them off. And so a little bit of exercise, walking 2 miles, walking 1 mile, maybe half a mile, may be enough to sufficiently activate those microglia. Those glia can go from not activated to activated in a minute or two. So you could feel horrible right after you exercise. That can last to 3 to 4 days, probably. Some people maybe longer. And it's really hard to exercise if every time you do it, you feel like you have the flu or you feel like you got hit by a truck. However, on the other side, we know that exercise, if you can keep it up and do it long term, there are benefits to you. So the trick here is, how do you find that type of exercise that you can do without exacerbating the symptoms? And I think most people probably already know this. You start as light as you can go, like ridiculously light, just a hair more than what you would do normally without exercising, and try to find that, and then you barely try to push that limit every time you exercise. And there are groups, we don't do this, but there are groups that specialize in exercise for fibromyalgia and chronic fatigue syndrome. I can't think of them off the top of my head, but there are centers in the United States that do that. So I would look up on that and try it. I understand if even a little bit exacerbates the symptoms. And since we don't do exercise therapy, I don't know exactly what to suggest. Probably ultimately, for people who can't exercise even a little bit, the solution may ultimately be giving them a drug that calms down the microglia, then getting them to do exercise. So now you've calmed things down, now they can exercise, then they can get the benefits of exercise, and then maybe over time you can pull away that drug and the system's been calmed down. So a lot of things, there's a lot of psychological problems where it's a combination of the drug and behavioral things that have the best effect. It's not one or the other. So maybe we have some exercise people at UAB. Maybe we'll try that, actually try something like low-dose naltrexone with exercise on top of it to see where we can get people.
Well, the question was about pain. Could it be that someone who has ME-CFS but doesn't have pain would have a different effect to the exercise than somebody whose primary is fibromyalgia? And so they may see an immediate response, negative feeling from the exercise, but then it does more good for them. Could there be some way that the two diseases respond differently or within a scale of severity of the response to exercise, any exercise?
Yeah, they might. My default, again, because I don't look at the exercise stuff specifically, my default would be going into it assuming that whether you have fibromyalgia or chronic fatigue syndrome, assume that if you exercise and push yourself, you're going to feel bad regardless. So I would take it light in either case. But yeah, certainly maybe fibromyalgia, chronic fatigue syndrome react differently. But both of them have that line of kind of that kind of exertional intolerance or that exertion really exacerbates the symptoms in both cases. So I think that general guideline is going to apply to both of those conditions.
Can a person have fibromyalgia first and then have it evolve into ME/CFS, or vice versa?
Yep, both. um, this is the tricky thing. Very controversial whether ME/CFS and fibromyalgia are actually the same thing, just slight different manifestations, or if they're totally different. And some scientists come hard on one direction or the other. I see them as more similar than different. My guess is that the treatments that work for one will work for the other, although we're going to start testing this in a month. So we're starting the first LDN for chronic fatigue syndrome trial, and we'll be recruiting people for that as well. Low-dose naltrexone seems to work really well for fibromyalgia. If it works really well for chronic fatigue syndrome, that suggests they're the same. If it bombs in chronic fatigue syndrome, which is very possible, it doesn't work, that's going to tell me that they're different things. I think I forgot the original question.
That was it, whether it can evolve from one to the other.
So, so a lot of times people meet case definition criteria for both by the time we come to see them or they come to see us. So I don't know which one came first, but the majority of people we see, they could be called having fibromyalgia and they could be called having chronic fatigue syndrome. It really depends on what type of doctor they saw first, whether they get the fibromyalgia or chronic fatigue syndrome diagnosis. But definitely you can have predominantly pain and then that kind of transition to fatigue over time. And in some people, the pain stuff, this is more rare, but the pain can go away and become predominantly fatigue. Also, somebody with chronic fatigue can have pain develop later on. So yeah, short answer is both of those can happen. I don't know the percentage, but I know they happen.
Okay. Since your theory is that Gulf War illness, fibromyalgia, and ME/CFS are caused by an oversensitized microglia, what would explain the different symptoms and the different triggers, such as ME/CFS is more often triggered by an infection, fibromyalgia is triggered by an accident or surgery, and we theorize that Gulf War illness is triggered by toxic exposures or vaccines.
Okay.
So if they're all coming from a microglia oversensitization, why do we see some differences in what predominates in the different, or what triggers the different conditions as the criteria are made up now?
Yeah. So the reason is because the microglia, the microglia are incredible cells. Again, these are the immune system cells of the central nervous system. They have to handle every kind of threat that can ever assault the brain. Every virus, every bacterium, every type of cell death, every poison, traumatic brain injury, and dozens of other things. These cells have to be able to handle all of them, and they do it by having receptors that are sensitive to all these different things. So the receptor that detects a virus is different than the receptor that will detect a bacterium. So also they have different responses. So it's not just a matter of you activate a microglia and it does the same thing every time. It will produce different cytokines and chemokines depending on what triggered it. So again, if you activate something like toll-like receptor 4 with a certain type of bacteria, you're going to get one type of inflammatory response. If you activate something like toll-like receptor 2, you'll get a different response. And there's a different mix of chemicals they produce, and that's going to lead to different symptoms. Some may be more pain dominant, some may be more fatigue dominant, cognitive problem dominant, and that's really the reason why.
So can you have microglia sensitization? Can you have some receptors more sensitive on the microglia than other kind of receptors, so that then if your trigger was a virus, and so the virus receptors are more sensitive and put out those kind of chemokines, and whereas if your trigger was maybe an operation, then those different kind of receptors for the pain in the microglia become oversensitized, and then they tend to respond more with the pain type chemokines and cytokines. Could that be the way it works?
Yeah, that's possible. It's hard to research. It's hard to look at the receptors on the microglia, but we would hypothesize that in different individuals, different subtypes of receptors have been overexpressed. So it's not so much that the receptors have become sensitized, it's that the microglia have put too many of those receptors on the surface of the cell. And the more receptors you have, the less of something it takes to activate those. So yes, I think in some cases, it's toll-like receptor 4 that's hypersensitive or overexpressed. In other cases, it's a different receptor. So that would predispose you to react to different types of triggers. Because if it were the other case, which is the microglia were just more sensitive, you'd react to everything. I mean, really, literally everything would be a trigger. And for most people, that doesn't seem to be the case. So I do think that it's subsets of receptors that are overexpressed.
So, and there's also a range within ME/CFS of symptom presentation. Some of us have one symptoms more than others, and so that's that. So it's not just the differences between the three categories of diseases,
right?
But there's even within a disease there can be a variation of symptom
and
presentation.
And even when you control, even if we were to take 100 people and inject them all with the influenza virus, so it's the exact same trigger, we would still get a lot of different responses. In fact, some people, given the exact same virus, wouldn't even get sick. Some people would die. So you have that whole extreme to the exact same thing. And some people would have all and everything in between. Some people would have a little symptoms, some a lot. Some people would just want to sleep. Some people would get pain. So even with the exact same trigger, you can have a huge range of symptom manifestations from person to person. Healthy people, so just ignore any chronic disease for a while. So you can, given that, it is not surprising at all that even within chronic fatigue syndrome or in fibromyalgia, you can get many different expressions of that disease.
So is it possible that vaccines play a role in causing Gulf War illnesses or ME/CFS or other neuroimmune diseases such as autism?
I don't do research with autism, so I will leave that to other researchers who can answer that competently. On the other conditions, yes, it is certainly a plausible hypothesis. We don't do a lot of work with the causes. I keep up with the literature, but that's really a different field, kind of epidemiological, like what happened to start this. We're more kind of on the later stage, which is how do we actually treat it? But you want to know the cause. That helps you come up with the treatments. Certainly, I think a chronic pain and chronic fatigue is a potential response to a vaccine, particularly if if you used a live virus, if somehow the immune system interpreted that as a huge assault on the system, which is more likely with some vaccines than others, that could cause chronic pain or fatigue, especially if you had multiple vaccines coming at you at once. So, one of the issues with Gulf War illness is that when those soldiers went over, we had no idea what they were going to be confronted with, biological weapons, chemical weapons. So they got vaccinated for all these things, and a lot of those things were experimental. So they're hitting their system with all these vaccines because they didn't want them to be at risk for some kind of weapon. But our immune system is not designed to handle 5 or 10 different assaults at the same time. So it potentially, unintentionally made the immune systems hypersensitive by doing that. And it might not have been any one particular vaccination, it was the combination of them. But we do know that certain antibiotics, and we know this for certain antibiotics can sensitize the immune system and cause problems years down the road. So short answer, sorry, I give a really long answer. Short answer is yes, vaccinations is a certainly plausible source of chronic pain and fatigue.
Okay. Evidently, you've used this term because somebody asked, what does excitotoxicity mean?
I think excitotoxicity. Yeah. I actually don't know if I've ever used that in a video. So the idea of that is if you have a neuron, something in your brain, and you activate that neuron too much, it can die. And the reason that happens is because every time that neuron fires, it lets in calcium. And if it fires too much, it lets in too much calcium, and that causes a bunch of enzyme changes, and it kills the cell. So that's typically not a concern with healthy individuals. And I don't know if it's related to ME/CFS or fibromyalgia. Where you usually see it is with taking methamphetamine. So if you hit a stimulant drug really hard, it causes your neurons to fire much faster than they're supposed to. And if you take a lot of methamphetamine, you can kill a lot of neurons in your brain. Another one is traumatic brain injury because it disrupts. So you hit your head particularly bad, and it will disrupt the neurons so they fire too much, and that'll kill the cells as well. So certainly that's a dangerous state, and that can certainly kill cells. I haven't seen it brought into chronic pain and fatigue, but I could look and see if those things have been connected. As far as I know, those are different conditions.
Your theory is an oversensitization of the microglia causing recurring neuroinflammation. But does your theory allow for an immune deficiency? For example, other studies have found low-functioning natural killer cells in ME/CFS, and some have low numbers. So how does your theory fit with that?
There's a couple ways I could address that. One, the really obvious one is if you have a portion of your immune system that is deficient, whatever bad thing that part of your immune system was supposed to take care of, that thing is now being allowed to flourish, and that's going to cause problems. So, and engage the rest of the immune system more than they're supposed to be. So, if you had a cell that was supposed to keep a particular bacterium down, and you no longer have those cells or they're not working, now you're going to get an infection that takes advantage of the situation. And now you've caused this big infection problem, and now the rest of the immune system is trying to compensate. And so a low part of the immune system over here can cause a huge exaggeration of another part of the immune system over here. All these things kind of talk to each other. The immune system is enormously complex. There's all these feedback mechanisms. So with very few exceptions, you never have a completely suppressed immune system or completely active. It's the pieces that are high or low. And like I said, it's maybe like a seesaw. Low over here can make it high over here, and that can cause symptoms. So there's no conflict at all between that. If you had low NK cell activity, there's multiple routes by which you could have inflammation in your brain through a chain of events starting with a low peripheral immune cell activity.
Oh, okay. And the hormone that you found that had the strongest correlation to severity of symptoms was leptin. Does pregnancy affect leptin? We've had some patients that have said they got better from their ME/CFS as a result of pregnancy, and then some, the pregnancy triggered them developing ME/CFS. So does leptin have any correlation with pregnancy as far as going up and down?
It's hard to tell. To really get at that, you'd have to measure leptin every few days across pregnancy, and no one has done that in humans. It's variable, actually. I don't think it's predictably higher or lower. I think if you're obese and you're pregnant, you will probably have an increase of leptin, but I think some people don't have an increase. So I don't, as far as I know, it's not reliably increased or decreased with pregnancy. It is, the pregnancy question is very interesting because there are some autoimmune disorders that will either get worse or better with pregnancy. I'm kind of embarrassed to admit it. I don't remember the list. Things like rheumatoid arthritis and lupus. I think rheumatoid arthritis gets better with pregnancy and lupus gets worse. I'm kind of cringing because I may be wrong, but I think that's an example of two things that are inflammatory but have very different responses to pregnancy, and that's very meaningful. If we can figure out more about why that happens, we can figure out those diseases. So if a lot of people came and if everyone said my fibromyalgia got better with pregnancy, we can use that information and say, okay, what other diseases get better with pregnancy? And there are a lot of autoimmune diseases that do, and say, okay, well, maybe it's like that disease. So I haven't seen a study on fibromyalgia or chronic fatigue syndrome in pregnancy, but I would like to see that. I think it would be very interesting.
And Rivka asked, just for clarification, is do we want the leptin to go up or do we want the leptin to go down?
We found that higher levels of leptin were associated with worse symptoms within person. So if you track them over 25 days, on their worst days, their leptin tended to be higher. Now, it's an observational study. We don't know if you force leptin down, we don't know for sure that would make the symptoms go away. All we know is that on bad days, they were high. So if leptin is the cause, then yeah, push it down and your symptoms may get better. And there is some animal evidence suggesting that if you give an animal leptin, they will become more sensitive to pain. So probably leptin is causing some of the symptom exacerbation. It's hard to push leptin down though. Yeah, it's a lot of dietary stuff and again, exercise. So we don't know what's the best way to quickly suppress leptin. So I can't recommend any treatments for it. But it's something that we're exploring.
And didn't you say that leptin has other beneficial uses? And so in our patients, it may not be that the leptin is out of the range of normal in the patients. It's just that the microglia is over-responding or in combination with the leptin. So the correlation up and down was with the leptin, but that doesn't mean that we necessarily have abnormally high or abnormally low. Is that right?
That's a very good point. You need leptin. If you don't have leptin, you'll want to eat all the time because one of the primary jobs of leptin is to suppress your appetite. So you don't want to knock it out completely. And leptin is involved in the immune system in quite a few different places. And yes, there's the basic science, the animal research suggests that leptin doesn't actually activate your microglia, but it can sensitize the microglia. So if you have a microglia cell and it has a high dose of leptin, that won't do anything except it makes the cell more reactive. And then if a bacterium comes along or a virus, that microglia cell will now activate more than it would have if the leptin levels weren't high. So it's that interaction of leptin and whatever your trigger is that probably leads to the increased symptoms.
Okay. So what is your theory on the high brain temperature and its connections to the debilitating fatigue and pain? So you're looking at chronic pain and chronic fatigue and multiple different illnesses. Why is the brain temperature study supposed to help you to figure out that? What is the connection?
What I'm trying to do there is, it goes back to this need for a test. We need a test where we can take somebody with fibromyalgia, chronic fatigue syndrome, and a lot of other conditions and be able to put them in the scanner and say, okay, here is the objective evidence. Here is what is wrong with you. In this case, we're trying to say it's neuroinflammation. We can take two people and say, yes, you have neuroinflammation. We can take this other person and say, no, you don't have neuroinflammation. That's what's needed to help with treatment development, because until we can find the pathology, you don't know what drugs to make. I mean, how do you know, if I were to make a new drug for chronic fatigue syndrome, where would I start? You have no idea unless you know what's wrong. So we need to show conclusively, both for ourselves and for everyone trying to come up with new treatments, what the pathology is. So that's what the idea of the scan is. Now, ideally, we'd be able to see the neuroinflammation. Ideally, we'd be able to see the microglia and see them in their activated state. There's just very few options to do that in a living human being. As I think I talked about in one of my videos, informational videos I did, you have to have the cells in a microscope, and you can't cut into the brain to do that. So we have to find indirect ways of doing that. So we're playing around with a lot of different techniques, and some of them use positron emission tomography, where you actually inject something that goes to the activated microglia. There are limitations with that approach. You have to inject something. It's slightly radioactive. It's very, very expensive. And so it's really hard to play around with that technique. So we came up with the thermometry technique because it's cheaper. It's much easier to do. You can do it in about 20 minutes. And you can do it every day on someone because there's no injections, there's no radiation. So we think that basically when you have neuroinflammation, your brain temperature will go up, and that's because that neuroinflammation is using a lot of resources, and that generates heat. Your body sends blood through your brain to cool it down to make your brain temperature the same or close to your body temperature. But if your brain has a very hyperactive immune response, that won't be sufficient to cool it down. That's the hypothesis. So we think that the brain, when it's has an inflammatory response, is going to generate more heat than the body can cool down. And so that's going to manifest as elevated brain temperature, and that can make you feel pretty bad. So it's probably not going to be the perfect tool, and it probably won't be the final tool, but it's something that's relatively easy that we can do just to get started in showing, is there any evidence of neuroinflammation and fibromyalgia and chronic fatigue syndrome?
Okay, the next question has to do with the brain inflammation and the circadian rhythm. Could the brain inflammation be influencing the reverse circadian rhythm that we see in these illnesses?
I'd have to look up the reverse circadian, just that people want to stay up at night and sleep during the day.
Yes.
I don't know much about that phenomenon. I will tell you that generally brain inflammation will absolutely wreak havoc on your circadian rhythms in general. I don't know if it predictably reverses day and night, but it will just disrupt it. So in most cases, so there is no circadian rhythm. It's just random. And again, you think about when someone has the flu, they'll sleep for 3 hours, wake up for a while, they'll sleep in the middle of the day. So certainly, and that's brain inflammation basically. So yeah, absolutely, you can have circadian rhythm disruption with brain inflammation.
Okay. And some patients have a low body temperature. Could this be the body's attempt to try to bring the brain temperature down?
It's an interesting hypothesis. I am not aware of any studies showing that that happens. Okay, I guess what I would say is if you have chronically low body temperature, and I'm talking about temperatures below probably 97 degrees Fahrenheit, make sure you get that checked out with your physician, because there are things like Addison's disease, there's hypothyroidism, there's kidney and liver problems. Those can lead to low body temperature and probably also low blood pressure in a lot of cases. If you have a combination of low blood pressure and low body temperature, make sure you get checked for a lot of things by your physician, especially, like I said, if it's below 97 degrees Fahrenheit. I don't know. Yeah, so basically it's an interesting question. I'm not sure if it's going to pan out that way, but what we're going to do is every time we bring someone in for that brain scan, we're going to do the brain scan, but we're also going to look at their body temperature. And so we'll see. I'm guessing that people with higher brain temperature, if anything, may have slightly higher body temperature. But if we get a lot of people with high brain temperature, low body temperature, that'll be really interesting. That will suggest exactly what this person's suggesting, which is the body temperature may try to compensate by lowering. Because if you have low body temperature, that should cool the brain off more efficiently, because it's the body temperature blood that does the cooling. So we'll look for it. We'll definitely know if that's true, because we're measuring all those things.
Okay, and is there a connection between the vagal nerve, the autonomic nervous system, and microglial activity? And that also kind of brings the idea of a vagus nerve stimulation, whether that would affect microglia activity.
Yeah, so the vagus nerve has receptors for peripheral inflammatory chemicals, like interleukin-1 beta is a big one. So if you have peripheral inflammation or a peripheral infection, that will dock on receptors on the vagus nerve, and then the vagus nerve will send that information into the brain and cause the microglia to release cytokines as well. So that's one of the routes that the body talks to the brain. When you have an infection in your body, it shoots that message up to the brain to say, hey, we've got a problem down here. You may need to be prepared up there in the brain for this infection to come your way. Start producing these cytokines to cause this inflammatory response. So yeah, absolutely. I think in some animal studies, if you cut the vagus nerve, you can drastically cut down on a lot of the symptoms of infection. So the fatigue, pain sensitivity, and kind of concentration stuff. I think a lot of that's communicated through the vagus. That's not the only way, but I think it's an important route. So yeah, that opens up, like you said, possibility of intervening in the vagus, usually in the neck, and with a peripheral, a nerve stimulator, maybe some kind of injection. We don't do vagal nerve manipulations, but there are techniques for doing that. So it is something worth exploring.
Okay. And I had to, Jared, you can't see this, but my picture left. And so while you were talking, I had to do something. So I'm explaining for everybody. I think I've got it set now. And so we're back to the way it's supposed to be. Okay. Does consistent low epinephrine in urine mean anything clinically or as an indicator of the disease mechanism?
I don't know. I've never done urine epinephrine screens. Yeah, I'd have to think about that one. I don't know of a connection. I'm not aware of many groups that do that. I mean, I know in some cancer screenings they might do that. Trying to think about HPX and stuff. Yeah, I'd have to think about it. I don't know an obvious connection off the top of my head.
Okay. And one study showed that ME/CFS patients have a limited range of motion. Another study showed that they have lax joints. Could range of motion dysfunctions be a stressor on the nerve system and cause that central sensitization or the inflammation signals from the nerves and the muscles going to the brain? Can it cause that?
Yeah. Yeah, I think that's one of the risk factors especially for fibromyalgia, probably for chronic fatigue syndrome as well. If you have hypermobility of your joints at a young age and you go through your life with hypermobility, that means your joints bend more than they're supposed to. And so a lot of people who were like, I guess ballerinas or whatever who are very, very flexible and use that, when they do that, they cause little tears to the joints and to the muscles and to the ligaments. Over their lifetime, it could be thousands or tens of thousands of little injuries that they may not necessarily feel, but the body is still picking that up, either through nerve stimulation or through inflammation that may be caused every time that happens. So there is a plausible hypothesis that hypermobility through a lifetime will predispose you to get something like fibromyalgia or chronic fatigue syndrome. And so then, yes, in that case, that's something that's likely to occur if you have these diseases and you also have hyperjoint mobility. Now, the earlier part is that you said one study showed that some people have less mobility, and that's where we get into this idea that there's multiple causes. So hypermobility is a cause, but if you have less mobility, that suggests that you have an inflammatory response in your joints, like if you have osteoarthritis or rheumatoid arthritis, and that's something else that could set off chronic fatigue syndrome or fibromyalgia as well, because if you have a chronic inflammatory disorder, that can set off this process. So yes, hypermobility and hypomobility could be associated with these conditions.
Okay. An Australian study associated chronic pain in women with T cells. Does that contradict your microglia sensitivity theory, or does it complement it? And does LDN affect the T cells?
Yeah, it's a compliment, actually. So that was, I'm going to blank on her name. I know the group. I know what they're doing. As far as I know, they're looking at T cells and they're looking at the receptors on the T cells. And I believe one of the things they found is that there's a lower than expected number of the interleukin-7 receptors. And I think they found maybe 3 or 4 other things. And if you put all those things together, you can predict ME/CFS. But they had to do with the cells having lower number of receptors than expected. Whatever we find, there's probably going to be a central manifestation of it and a peripheral manifestation. So I don't think those conflict. And low-dose naltrexone, I think you asked about LDN, right?
Whether it affects T cells.
Yeah, the T cells have toll-like receptor 4 receptors, TR4 as well, just like microglia. So the sites where we think the LDN are going, it can go to the microglia, or it can go to those T cells. So absolutely, in fact, in addition to central disorders, you see LDN used for Crohn's disease, which is a peripheral gastrointestinal inflammatory disorder. So we know that LDN is also working in peripheral inflammation as well. So that definitely fits together. We don't know I can't tell you what the pathway is, but there's nothing conflicting about having T cell dysregulation in the periphery and microglia dysregulation in the brain.
And what is the role of GABA glutamate balance in the kynurenine pathway? I'm sorry if I don't say it right.
Yeah.
And how they are affected by neuroinflammation?
Yeah, there's a lot of stuff there. So when you have inflammation, it affects the function of neurons, and that can affect serotonergic, dopaminergic. It can affect your GABA, glutamate. Basically, any pathway is open to be affected by inflammation, especially if it's chronic. So that system you're talking about is involved in, I forget the chain. I think it's basically tryptophan production and then probably serotonin production, maybe niacin. There's different pathways in that system. So my general understanding is that when you have profound inflammation, you can push that system into one direction versus the other. And I think what actually happens is you have serotonin deficiency when you have inflammation. So yeah, absolutely. Inflammation changes. So GABA is supposed to be, so switching to the other one, GABA is supposed to be, it puts the brakes on things. So it slows down neurons. When you have inflammation, the microglia can switch GABA from being the brakes to actually being an accelerant. So it switches their role in particular neurons, and that's associated with the fatigue and pain. So basically, yeah, inflammation can affect every neurotransmitter, again, dopamine, serotonin, which is another reason why you can have a lot of different symptoms. And at the end of the chain, if you feel something different than normal, it's probably because one of your neurotransmitters is not acting properly. But the cause could be inflammation. So and that's why some of these FDA-approved medications work. They'll change your serotonin, they'll change your norepinephrine. That may make certain people feel better. That doesn't mean that that's what the problem was. The problem is actually the immune system that's causing the dysregulation of the neurotransmitters in the first place. But inflammation basically changes everything in the body. So yeah, GABA, glutamate, all the serotonin systems, all those are affected.
Okay, and we're coming up on an hour, and we were going to, I know it went quick, didn't it?
It did for me, but yeah.
Uh-huh.
Wow.
Let me ask this one last question, and I want to remind everybody the questions that we are seeing in the chat area, we are capturing those, and we will get to those in the next one. But here's the question, one of the pre-submitted ones. Have you found evidence of microtrauma in fibromyalgia patients the same as the trauma that you see with post-concussion syndrome?
I have not seen that. That's usually done with diffusion tensor imaging, or DTI, which is a scan that looks at white matter in the brain. And you usually see that done, with traumatic brain injury and concussive injuries. I think those scans are not to the point where we can use them diagnostically. I think we need to improve the resolution on them. I think I've seen some studies that show, there certainly are some studies that show that fibromyalgia have some different white matter structure than healthy controls. I'd have to see those repeated, and I'd like to see better white matter scans to know for sure what's going on. So I would say it's an interesting direction. I haven't seen enough literature enough to tell me whether or not there is white matter differences, because if there are, that means there is some damage happening to the brain, because those are little micro lesions happening in the white matter tracts. That means the axons are being damaged, and that interferes with the ability of the neurons to send their impulses, which is similar to multiple sclerosis, but a lesser degree, because in MS, the damage is very large. Those plaques are large, and micro tears are much smaller, but they could still affect the function. So I think it's important to investigate. And we're working on those DTI scans. We're trying to get, the higher the resolution you get, the smaller things you can see. And so it's a direction that we want to go in.
Okay. So do you have any closing remarks before I go on to my instructions at the end?
Nope, I don't. I would say people keep tuned. We'll do the Q&A sessions occasionally. More frequently, I do kind of these quick 7-minute or so videos about different projects. So, keep an eye on the YouTube channel or the Facebook page. I try to announce things in both places. And I haven't decided what I'm talking about next week, but I think I want to talk about the, all the stuff coming out of the NIH with the new funding opportunities, because I think it's very exciting because that's what we need to get all this research going, get more people interested in this type of research. So, but we'll see what I end up talking about. But I'll try to put those out every week. If that's too ambitious, every week and a half or so. But yeah, that's all I'd say right now is just keep an eye on that. And that way I'll always try to talk about the most important stuff coming out of the lab.
Yeah, and we'll do another question and answer session hopefully next month, and we'll get more of these answered, and we'll have this recording up. So bye-bye, Dr. Younger.
Okay.
We will talk to you or see you on your YouTube.
Okay. Thanks, Tina. Bye.
Okay, so here's where you can keep in touch. There is the Younger Lab Facebook page that you can use this Bentley to get to. You can go to the website, and there you can sign up for his newsletter, and you can also subscribe to this channel. So I want to thank everybody for joining. We had about 55 at the most at one point. I hope to have the recording of this up within the next 24 hours, and then you can share it. You are welcome to still submit questions to the Jared Younger Lab at gmail.com, and we will collect those and answer them next time. And thank you for attending.